Well, hi everyone. Thank you for joining me. My name is Tyon, and I will go ahead and present to you the Leaders of Tomorrow internships. What I'll do, I'll give you a brief overview about the Leaders of Tomorrow internships, and I'll go into our client, the U.S. Department of Veterans Affairs. I'll tell you more about their electronic health records program and the deliverables that I did, focusing on the standardized guidance product, scenario development, and other work completed. And then I'll go into challenges, lessons learned, recommendations, and I'll close out with questions. So the Leaders of Tomorrow internship is based in Washington, D.C. It was an 8-week program starting June 3rd to July 26th, where we took a 1 credit hour course at American University. There we engaged in weekly discussions as well as different seminars where we talked about networking, resume building, informational interviews, just tips to engage around Washington, D.C., and also how to apply for a government job, because those are different when it comes to the private sector and governmental sector application process. With the National Coordination Center, we did shadow our NCC mentors. We engaged in discussions and working sessions, as well as developed processes for communication, attended weekly meetings, round robins, where interns as well as their mentors sat down and we talked about our barriers, accomplishments, tasks that we were working on, and also lessons learned. Also lunch and learns, where we had industry leaders from the VA, the DoD, as well as Cerner come in and talk about their careers, what they're focusing on, and how to develop our careers. So our client is the U.S. Department of Veterans Affairs, where their mission is to fulfill President Lincoln's promise to care for him who has joined the battle, but who shall have borne the battle for his widow and for his orphan. During the time of the Civil War, President Lincoln saw that soldiers were sustaining injuries, they were reckoned with illnesses, as well as losing their life on the battlefield. So he decided that he wanted to do something about this. So the VA is to fulfill President Lincoln's promise. There are 3 subdivisions where you have the Veterans Health Administration, the Veterans Benefit Administration, and the VA National Cemetery Administration. For fiscal year 18 to 24, there are 5 priorities that they plan to achieve modernization, which is customer service, the Mission Act, electronic health records, business system transformation, as well as suicide prevention. For this presentation, we'll focus more on the electronic health records modernization program. So the EHRM was in May 2018, the VA awarded Cerner a $10 billion contract that has later ramped up to $16 billion contract to replace its own system, the Cerner Millennium solution. So you could only imagine what they want to do is to create between the time a person enlists in the DoD to the time they transfer into veteran status. So, increasing interoperability across the board as well as with community care providers. So there are 3 major components where they want to modernize VA's legacy system and associated infrastructure, provide veterans and clinicians with a complete picture of the patient's medical history, and implement a new EHR system that is interoperable with care providers. So why is this even important? Well, in order for eligible veterans to seek compensation as well as receive care, they have to identify a service-related or a service connection injury or illness. And how they plan to do that, they have to identify at least one of the 2 factors, which is chronicity, meaning an illness or injury that was sustained during military service or developed afterwards and has been diagnosed as a chronic disease, or continuity, meaning that they had an injury before they entered into military service and has worsened since then. And those evidence can be found in medical records and exams or expert opinions. Right now, it is difficult to provide evidence because the information is stored within a fragmented EHR system. So if you're thinking about the DoD and what the information they store, as well as the VA, none of them are talking to each other. So how can we plan on providing a complete picture as well as ensuring that veterans are actually receiving the disability compensation and the services that they are obligated or they have a motion for? So the VA to Cerner's timeline begins in June 2000. It announced that it will be transitioning to Cerner Millennium solution. So for June 2017, VA announced its transition, or that it will transition to the Cerner Millennium solution. In May 2018, VA actually signed its contract with Cerner. June 2018, they established the Office of Electronic Health Record Modernization Program, and I'll tell you a little bit more about that in future slides. In October 2018, VA kicked off that initial operating capacity where they went into Vision 6, and I'll tell you more about what a vision is, to assess their current environment, making sure that they have the infrastructure, meaning software, hardware that was needed to actually be ready for the new implementation. So in March 2020, they're able to launch that Cerner Millennium successfully. So when I'm referring to a vision, I'm talking about a Veterans Integrated Service Network, or a coupling of healthcare networks within the VA. So West region of the United States, and also I'll refer to Vision 6, was in the border between Virginia and North Carolina. So the prime contractor is going to be Cerner. Cerner is one of the leading suppliers for healthcare technology. And the reason why they kind of chose Cerner was because the DoD has already begun its transition to the Cerner Millennium solution through their MHS Genesis program. So with that, it's also able to integrate its electronic health records across the board. If you think about service members that are actually stationed and overseas and trying to bring that information back into the United States, you need a robust system that can actually afford that. So the Cerner Millennium solution is something that they voted for. How does the National Coordination Center kind of work within this? So this is where I did my internship, and they are one of the 24 subcontractors, which is a low-for-profit or purpose-for-profit company. It is to create connect the nation's brightest minds to help solve some of the most pressing issues in healthcare. And the current project is the EHRM project. How they're going to do this? And Task Order 7. So whenever a company or a subcontractor wants to receive work or assign a task, they have to actually develop a proposal and bid for that task order. So they're focusing on IPBAs, or industry best practice advisors, on board, or what we refer to them as subject matter experts. And also they are helping with the revenue cycle, which by the time that I left, they already completed and finalized, and they're moving on to more task orders. So NCC is supporting foundation pillars, which is going to be interoperability, innovation, workflows, telehealth, patient portals, and quality and safety. So what did I do during my time at our internship? I worked on the standardized guidance product, or discussions around that, scenario development, and other work completed was verification, integration, validation, mock go live documentation, data integration, and IPBA interviews. So what is a standardized guidance product? Without going into much detail, it is a centralized repository that houses all directives, policies, handbooks, standard operating procedures, and clinical guidelines. So essentially, you can do ad hoc search. So if you wanted to learn about suicide assessments or counselors, you can enter that information in, and all the results will come up for the policies or standard SOPs for that topic. So I was decided by my mentor to develop a problem definition for their SGP, which has led into my thesis statement, and I'll add the standardization of clinical based on quality care outcomes. So my problem statement that I came up with was the second. It's at a risk due to a misalignment between policy and clinical practice that impacts the clinical decision-making process. So what I mean by this, during the process of them trying to come up with the best practices for the clinical content decision-making, they're seeing a variation between what the local level policy is and what their national directors are asking levels to actually achieve. So step into 3 levels. You have a national level, which is called the enterprise, then it's the vision level, and then the local level. So currently, there is not a standard or baseline to help determine what is the best practice and how much customization is appropriate based on your patient population. So we look into, so how is Cerner or how is the VA kind of combating against this issue? They developed the Office of Electronic Health Record Modernization Program. And what it is, it was established to manage the preparation. It has 18 national councils that are responsible for reviewing and finalizing their standardized national clinical and business processes. But when they're actually going in to look at the clinical and business process, they're seeing this variation. They're trying to identify how can we leverage the playing field to make the best decision for what should be. So there are 5 major groups that are responsible for the redesign process. When we talk about the national councils, they make up about 85% of the decision, which determines the national baseline. Then you have the vision in the local level, which come up with about 15%. So they're in charge of identifying variations or identifying variations where the national directives take that into an account to establish a baseline for it. So the major takeaways from actually engaging in the working discussions is that there is a lack of standardization, which is causing a misalignment, causing poor quality reporting, causing medical errors and uncertainty of the best practice. So according to research, whenever a hospital receives a negative outcome, it's kind of impossible to determine whether or not appropriate measures were taken to avoid the outcome in the first place, as there isn't a baseline established. So what we want to achieve is having a point of reference for all the process of the care, kind of leveraging out the playing field. We customization based on the population characteristics and the services that they render to determine how much customization is appropriate. So the other areas of focus that I did as far as identifying variation was looking at VA's quality reporting, which is their analytics for improvement in learning, which is their sales quality reporting. And basically it summarizes the hospital performance data. I took account of their care transition, where it measures this patient's perspective of care provided when transitioning out of the hospital setting. So it composes of 3 questions that kind of that we want to understand that the patient understands the doctor's orders as well as of their preferences. So I transitioned that into, I found this information on the VA's website and I compiled it into a data set where this information is talking about the Vision 6 and where you see the higher value, the better. So according to the data, the national average is 53.14%. So anything that's at that level or above that level is doing pretty good. So the North Carolina Specialty Hospital is about 68%, right? But when you're looking at this information, yes, you see that there is variation, not alarming variation, but you don't understand what's causing this. So after looking at the quality reporting, I realized, yes, you can look at it, but you have to do further data analysis and analyze the data a bit further to identify if there's even a need for the SGP. The next step I looked at was that that the VHA awarded a $22 billion contract to develop an HL7 CDS tool or a clinical decision support. During that time, they brought in 3 companies, and with these 3 companies, the CDS tool will incorporate alerts, reminders, clinical guidelines, order sets, data reports, databases, documentation templates, and clinical workflow tools. Their aim was to standardize clinical content for the checklist, documentation templates providers need to actually document the care that they provided by organizing clinical knowledge in a universal fashion. The challenge while focusing on this project was once again, the variation across the board between the clinical system and processes around the massive healthcare network. How they did it, leverage medical doctors, informaticians, data scientists, software developers to come up with the best practice for their clinical content. At the moment, there isn't a system that is compatible with the XML files. So the Vista isn't compatible with the XML files. I anticipate if Cerner deems it appropriate that they would incorporate this CDS tool into their Cerner Millennium solution. Um, After looking into their CANARD system, this is what they call their clinical decision support, the evidence backing their need for this or the clinical guidelines are provided by VA and DOD. But once again, if there isn't a baseline established, we're not efficiently analyzing information that should be incorporated into the clinical content. So my recommendation is to couple the CPS tool with the standardized guidance product. Therefore, you have a centralized location to go to enter these terminologies, to know what is the best practice, what is the policy stating for a suicide prevention, and coupling that with this clinical decision support system. Establish a baseline, we can start being more patient focused according to our patient populations, especially at the local level, to make sure that we are rendering care that is patient appropriate. The second thing that I worked on was scenario development. And scenarios are basically descriptive text of simulated events that's usually conducted in a healthcare setting. And whenever you're building out a scenario, right, or use cases, you want to make sure that you are having a transition of care between the admissions process, inpatient, step down unit, and referrals. So you have a group of doctors, and this is how we conducted it, kind of like in a room of such. You have doctors and nurses all chiming in, and they'll sit down and hash out what is VA appropriate. So you have a 92-year-old patient comes in, 92 white male comes in with chief complaints, and then you go from there. So you start with the admission process all the way to the discharge process. And these scenarios and use cases then become test scripts that are needed to ensure that the system is working correctly and that the user is also using the system as should. So is the system verifiable? But due to lack of standardization, it can be challenging to develop these scenarios if every clinical process is accounted for. So having one universal process of care kind of makes this issue go by faster. Other work that I completed during the internship, once again, I did a slide presentation on verification, integration, validation. I engaged in mock go live documentation where I presented a mock go live strategy plan for it. And how I did it, I looked at IPVA interviews. So when I was conducting these interviews, I came up with a list of questions. I began to research case studies regarding EHR implementation. I wanted to understand their strategies. I wanted to understand their areas of improvement, challenges, and just general insight. I then came up with a list of questions, and I was able to sit down with some of the IPVAs to get feedback. From that feedback, I then incorporated in the mock go live documentation to understand how well or what should we do to implement a successful EHR system. And when I talk about mock go live, I'm talking about a dress rehearsal, an opportunity for the end users to actually practice using the EHR system before it actually goes live. I also engaged in data integration, where we compile NPI numbers for all certified providers within the VA. So if you think about every state that the VA is in, we went in and actually tried to find their NPI numbers and compile it together so we can create a database for that. Some of the challenges that I experienced during my internship was the ability to manage ambiguity. So whenever you're working in a large or small setting, it is hard to determine what is the best outcome. Sometimes you're not giving the proper instructions. Sometimes sometimes their system requirements are quite vague. So this is what I need from you, and this is when it's due. So it's hard, it gives you an opportunity to be a problem solver, to make these tough decisions, to see if you are actually listening to the client's need, to develop a solution that is appropriate from them. So not only was it it was also one of the most essential skills that I developed during my time there. Some of the lessons learned was team dynamic and organizational culture. I never met a more cohesive team than NCC. They all cared about each other's needs. They cared about their vision. They cared about the core values of each one. And whenever we engaged in these working sessions or discussions, it was never an opportunity where anyone dismissed. we made sure that, yes, we'll take your idea into consideration and maybe we need to elaborate more on it, but we're not going to disregard you. So it gave everyone, empowered everyone to actually talk more about what we can do to further the VA's mission. As well as we had an opportunity, some of the veterans were coming in to view the memorial. So veterans from the World War II and the Vietnam War came into DCA. And while they came in, we kind of cheered them on and applauded them and welcomed them back home. And it kind of brought it all in full circle. Who are we doing this for? And so with the organizational culture being a purpose-for-profit organization, I stand by MCC and what they believe. And also being a sponge. So during the internship, that's one of the most times that you can actually make sure that you are gaining all the knowledge from your mentors, from the staff, or just by walking in the office, just talking to someone. Being a sponge, keeping your feet to the ground and your ear to the wind. And some of the recommendations that I would ask NCC to do is to allow students to engage more in these lunch and learns. They are beneficial to know what your career path will be based on your interests. You have the opportunity to network and you might even land your job. And also being able to engage in the working sessions, being able to develop mock deliverables that actually be final projects for the interns. So for my acknowledgement, I do want to thank the entire NCC team for just giving me the opportunity to work with them. Dr. Carr, who's our CEO, Larnie, who's the VP, Dan, Jennifer, Joanna, Elena, and Elaine. They have all fed into me as mentors, and I appreciate them so much, as well as my fellow interns. In 8 weeks, I never thought that I would be able to grow so much professionally and personally, but I did, and a part of that was attributed to them. And I also want to thank Dr. Kitzmiller, Dr. Mustafa, Dr. Counson, and my UNC friends and colleagues. I just thank y'all so much for just feeding into me, for encouraging me, and just being there whenever I need you. And that's it. Now I have room for questions. Yeah, I'll be continuing with them. So in December, yes, I took a full-time position with them as an associate. So I moved in 2 weeks, well, no, I'm sorry, 2 months to DC. Yeah, yes. Thank you. No, 8 weeks.